Good afternoon, everyone. Welcome to the webinar hosted by CMQCC, The Value of Data to Advance Equity-Based QI, introducing the new Maternal Data Center Equity Dashboard. This is Valerie Cape at CMQCC. I'd like to introduce those who will be presenting to you today. Terri is a clinical lead at CMQCC. She has been an inaugural member of the Maternal Data Center and most recently has been working with the QI Academy project and the birth equity work. Ann Castles is the Associate Director of the Maternal Data Center. We have a few housekeeping notes for you. All lines have been muted to eliminate background noise. We will have an opportunity to address your questions at the end of the webinar, and they can be typed in the chat box or the Q&A. The webinar recording will be available on the CMQCC website along with the slides. And if you have any other questions, our contact information will be provided at the end of the presentation. With that housekeeping, I'm going to go ahead and turn it over to you, Terri.
Okay, thanks, Valerie. We are here to talk about data and how we can use data to establish a need for equity-based quality improvement. Next. So when we look at the national landscape with regards to the current state of maternal outcomes, we see a stark and concerning upward trend in maternal mortality, severe maternal morbidity, as well as cesarean births. Next. Some of the agencies who calculate these outcome statistics utilize different parameters, but regardless, the trend should concern all maternal health care providers. Next slide. So what does the maternal mortality picture look like closer to home? Many of you may have seen this slide, but this depicts the history of maternal mortality in California. California has over 500,000 births annually, which is 1/8 of all births in the country. The red line shows the maternal mortality rate for the country from 1999 through 2013, when the last maternal mortality reviews were looked at. The blue line reflects the California maternal mortality rates. So as you can see, the mortality rates peaked in 2006 here in California, and this concerning trend prompted the California Public Health Department to mobilize efforts to identify and address this crisis. The first California Maternal Mortality Review Committee was formed to review each mortality case to identify quality improvement efforts to improve these outcomes. Next. CMQCC was formed at that time with the resulting next toolkits and collaboratives to provide next an implementation roadmap to intervene on the major causes of maternal mortality. Since that time, due to the efforts of all of the partners and hospital teams and their unwavering efforts to make a change, next, we have successfully reduced the maternal mortality rate here in California by over 50%, in direct contrast to the rising national maternal mortality rate. Next. So in 2018, the National Center for Health Statistics at the CDC presented this data of maternal mortality by state. As you can see, the vast difference in outcomes across the country. And you can also see that all of the collaborative work of the hospitals in California has resulted in one of the lowest maternal mortality rates in the country. This is the strongest argument that data utilized to drive clinical quality improvement can result in positive outcomes and, in fact, save lives. Next. So where does the data now drive us to refocus our quality improvement efforts? So maternal mortality is defined by the World Health Organization as a death during or within 42 days of delivery and related to the pregnancy. If we take a step back and look at national maternal mortality outcomes by race and ethnicity, the picture becomes bleaker. Although there is a rise in maternal mortality rates for all racial ethnic groups, with the exception of the Asian community, there is a significant rise in the non-Hispanic, Black, and American Indian communities. Next. So let's come back to California and see how the race ethnicity outcomes are presented here. So how are we calculating maternal mortality by race? So the data is produced by the California Department of Public Health using race and Hispanic ethnicity from the birth certificates. Because of the small numbers for many of the racial communities, the rates are calculated by 3-year moving averages, which you can see across the bottom. Every race and ethnicity maternal mortality rates rose during 2001 to 2009 and then started to fall, particularly after 2010. The mortality disparity ratio, which is identified by the dotted red line in the middle, is calculated by dividing the rate of maternal mortality of African American mothers into the rate of white non-Hispanic mothers. In other words, how many times higher is the Black outcome compared to the white outcome? In the US as a whole, the rate has varied between 3 to 4 times higher for Black women. We see the same ratio, 3 to 4 times higher for Black women in California. When the rates for Black women and white women fell in the period between 2010 and 2013, it fell equally for both races, so that disparity ratio remained at 3 times higher. Next. But we treat everyone the same, right? My guess is if we asked everyone on the call, we would hear from all of you that you have said this or heard it said by your coworkers at least once, and I know I'm not excluding myself. But I've had the opportunity to learn and internalize the difference between equality, which is treating everyone the same, and equity, which is meeting every person at their level of need. So if we have a giveaway opportunity drawing and we offer all of these winners the same bicycle, we might be treating all of the winners the same. However, would each of these individuals feel that they had received a gift that would benefit them? Maybe not. However, if we provide the individuals with the means of transportation that meets their individual needs, then it becomes a win-win for both parties. This is a crucial component as we consider the opportunities ahead of us in the use of data to drive birth equity quality improvement efforts. Next. So the next question is usually, but this is happening somewhere else, right? It can't be happening at my hospital, can it? The answer is maybe. Next. Just like the data that we first saw in 2014, care varies from hospital to hospital in California, especially in a state as large as ours. This was especially true when looking at NTSV C-sections when we first started the Supporting Vaginal Birth Collaboratives back in 2015. This graph depicts the hospitals of California in 2014 and their individual NTSV rates at that time. Each of the blue bars is one hospital. The red line is the national target that we all know and love, which is 23.9%. You can see that the outcomes, however, vary greatly across the hospitals in California, with NTSV rates ranging from 12% all the way up to 70%. Sometimes, I know it's a little difficult to look at just numbers, but look at this slide from a pregnant woman's point of view, and she is trying to decide where to have her first child. So, however, there is good news here, because where there is variation, there is opportunity to learn from each other and to improve care. Next slide. So this is also true in the NTSV rates by race across hospitals in California. So Black births are concentrated in about 1/3 of California hospitals. 90 hospitals out of the 240 actually account for 86% of all Black births in the state. Because the proportion of Black births in California is actually low at 5.5%, we restricted this analysis to hospitals with at least 150 Black births over 2 years from the period of 2015 to 2016. Here we are examining whether at the same hospital Black women have higher rates than white women. This ratio is simply the Black rate divided by the white rate. So if the hospital has the same rate of NTSV C-sections for both races, the ratio will be 0, which is depicted by the red line. If the relative risk is less than 1, then that means that the relative risk of the Black women is less than having a C-section than of the white women. However, if the relative risk is 2, then that group has twice the chance of an NTSV C-section. As you can see that not all hospitals are the same, and that the relative risk varies significantly amongst the hospitals across the state, with the average NTSV rate for white women at 25.3 and 30% for Black women at the time this study was completed. Next. The same story also exists when you look at severe maternal morbidity. The variation amongst those same hospitals remains, and in fact shows a risk of severe maternal morbidity for Black women almost twice as high as the white women. Next. So the baseline question is this happening at my hospital? So I would now like to turn the remainder of this presentation over to Ann Castles. She is the Associate Director of the California Maternal Data Center, and she wants to preview the newest addition to the MDC with exciting possibilities that will allow you to quickly identify birth equity, quality improvement opportunities at your facility. Take it away, Ann.
Hi, thanks, Terri. Hopefully everyone can hear me.
You're good.
Great. The birth equity section in the Maternal Data Center is brand new. Everybody should see it on their MDC homepage as of today. I'm going to be walking you through that new section, showing you the various features and how to interpret the data. But first, I want to underscore our goals in creating this new section. As I think everyone knows, our mission at CMQCC and the Maternal Data Center is to provide data that motivates and supports quality improvement. With these new birth equity tools, we're aiming to inform awareness of how hospitals' practices and outcomes very often differ across racial and ethnic groups. We hope that you'll use these data to start a dialogue on birth equity with every QI activity that your hospital undertakes. So with that background, let's start looking at the new section. It will be on your home page. It should be over on the right-hand side of your home page. Everybody should be seeing it as within the last few minutes. It would have popped up in your Maternal Data Center homepage. It will look like this. It has quite a bit of information in it. Right from the home page, you are going to be able to link to two key measures that we're hoping you'll look at through the lens of birth equity. So that's the NTSV cesarean section rate and the severe maternal morbidity rate. Then there's also a section that we call more measures that is just a list of more measures that we also think are ripe for looking at through the birth equity lens. There is a link to more resources, and there's also a link to an automated birth equity PDF report. And I'm going to start there today. It is a one-click report that helps you easily share data on birth equity that is specific to your hospital with your colleagues, with leadership, with staff, with physicians. To start using it, you just click on that birth equity PDF button, and you're going to see a drop-down menu that is going to default to non-Hispanic Black, but that is going to provide other options if you open up that drop-down menu. Now, one of the reasons that we decided to default to the Black population is because it is in this population where we see both nationally and statewide the most disparate outcomes. Okay. That said, we recognize, we know that there are some of our Washington and Oregon affiliates on the phone call as well. And for some of you, you might have other target populations where you suspect there are disparities. And so you can open up this toggle and choose one of the other options. Another note is Washington and Oregon hospitals will see a slightly different list. If you are a Washington or Oregon hospital, then you will see options for Native Americans, as well as Pacific Islanders broken out from Asians. Once you have chosen your target group that you'd like to examine, you click the green PDF button, and then automatically your PDF report will generate. It is a one-page report that has a lot of information in it. Okay. There are the two key measures of severe maternal morbidity and NTSV cesarean delivery rates. And within these graphs, we're making three types of comparisons. Okay. we know there's a ton of information on this graph that we wanted to squeeze all into this one page. So right now, I'm going to help you unpack it. First thing to know is we're going to spend the next few minutes talking about all the different comparisons you can do within that PDF report, but do know that we have some interpretive guidance at the top. And so you can always refer back to this for a summary of, hey, how do I interpret this? What does this mean? Okay, so just know that's right on the report itself. Okay. Now let's start talking about the comparisons we can make. Comparison number one is going to be the comparison of your selected race ethnicity group based on the selection you made right before you generated the PDF report, compared to all others. And by all others, we mean the aggregate of all other cases, excluding the target population, because we don't want their numbers weighting into the all others. Okay. In this particular example, the orange bar represents the target population that we selected of our non-Hispanic Black delivering moms, okay? And then the blue bar represents all of our other hospitals' cases. Now, keep this concept of target group compared to all others in mind, because we use that throughout the birth equity section in the Maternal Data Center. So we're not comparing Black to white or Asian to Hispanic, okay? We're gonna compare whatever your selected category was to all of the other cases. Now, so what do you do with these graphs? Okay, this is, I'm using examples. All of the next set of examples are going to be showing NTSV cesarean delivery rates. So the orange bar represents that Black women at this hospital had an NTSV C-section rate of 33%, whereas all other patients served by this hospital had an NTSV C-section rate of just under 29%. So some key questions to ask yourself as you're going through these graphics is, first and foremost, do we see a disparity in outcomes between the different groups? And then hopefully your next question is, if there is this kind of gap, are we willing to make a concerted effort to address it? Next comparison, okay? I'm adding on a new pair of bars here, okay? And in this comparison, you're gonna be able to look at your baseline data compared to the most recent 12 months. So you're gonna be looking at progress over time. Just so you know, okay, the baseline represents a cumulative 2-year period that, at least for right now, we're using 2016 and 2017 for the baseline period. And then the most recent 12 months literally represents the most recent 12 months of data that you have submitted to the Maternal Data Center. So if you're up to date on your data submissions, that's going to be at least a July 2018 through June 2019 rate. And if you're behind, it would be older, of course. The goal here is to assess your progress between the baseline period and your more recent period for your hospital. Again, recognizing that the orange bars represents the target group. In this case, we're looking at Black delivering moms who had an NTSV C-section rate among them of over 30%, okay? Baseline for all others was 23.6%, and you're gonna wanna compare the two orange bars. Did we make progress in reducing the NTSV cesarean delivery rate among our Black mothers? And for this hospital, the answer was yes, there was progress made, okay? And it looks like there was also some reduction for all of the other patients. And the good news is, not only was progress made, but the gap also shrunk, so that's always good. But then the follow-up question is, well, does the gap still exist? And what more can we do? Comparison number 3 Okay, I'm adding on another 2 pairings here. Okay, we're starting to get a little crowded, but all of this is information that folks want to know. Okay, here now we are comparing own hospital data, so for demo hospital, to a peer acuity average. Okay, and this is going to be the average across all other MDC participating hospitals that have the same nursery level as your hospital. So if you are a nursery level 1 hospital, you're going to see the average for all the other MDC hospitals that are also level 1s. If you're a level 2, you'll see the level 2 averages. If you're a level 3 or 4, you'll see that average, okay? So the idea is that you are comparing yourself to other hospitals that serve the same acuity of patients, okay? For this type of comparison, what you're going to want to do is you're going to want to choose the time period, okay? And so probably you're going to want to choose looking at the most recent 12 months, okay? And you're going to want to compare your hospital's rates to the average rate for your peer hospitals that are also level 2 for that most recent 12-month period. And again, first you'll compare orange bar to orange bar and say, oh, the NTSV C-section rate for my Black mothers, just under 35%, but my peers have a rate of just under 28%, which itself isn't necessarily great either, okay? But there's something I'm doing differently from my peers. And then you can make the same comparison for all others at your hospital versus for your peers. And so a key question here is, how do we compare to those hospitals? And begs the question of, what are we doing differently from our peers? So again, this is a lot of information. Also on the report, note that at the bottom, we do define the time periods. So you can see that baseline represents 2016 and 2017. You'll be able to see that the most recent 12-month period represents whatever your most recent data submission is, and we'll give you the exact months. And the other thing that we want to keep in mind throughout this birth equity section is a warning around small counts. Because think about it, we're looking at, usually we just look at an overall NTSV C-section rate or an overall severe maternal morbidity rate. Okay. We're now taking that overall rate and we're parsing it into much finer subcategories. So we're looking at NTSV rates for Black women, NTSV C-section rates for Hispanic women. Okay. And depending on your hospital's delivery volume, sometimes these counts can get very, very small. And our strong recommendation is go into the other sections of the maternal data center in the birth equity section. Okay, and I'm going to show you that in just a second. See what the denominator counts are for the population that you want to take a look at, your target population. And if that denominator count is less than 20, and I will show you where to see it in just a second, then I would not print this report, okay? That rate is not going to be quite robust enough for you to share around, okay? So that's our recommendation. If it is under 20 and you still really want to make a point, absolutely go ahead and do that, but just be very wary and let the people seeing the data know that the denominator counts for the target population are small, okay? And so they need to understand the data in that context. Okay. We're going to move now away from the interpretation of the PDF report. Okay. We're going to go back to our home page, and I want to start talking about the other features that you'll find that are interactive features in this new birth equity section. Okay. So once again, you would be able to click into NTSV C-section or severe maternal morbidity, and you will be taken to a whole host of additional functionality. from a birth equity lens, okay? Or you can also click on more measures, and you're going to see an additional set of measures that, again, are going to be very useful to look at through that birth equity lens, okay? And this is the set of measures that we've selected from the outset that we think are useful for looking at through the birth equity lens. So you simply choose any one of them, click into it. I'm going to, let's say that we've clicked NTSV cesarean birth rate. And then you're going to see a graphic that looks like this. And again, I'm going to go through and walk through and explain the bar graphs. But before we do that, I want to point out a couple of navigation items. First is there are going to be 3 tabs along the top of this. And each of those tabs is going to give you a different view and a different set of tools to focus your birth equity QI activities. Okay, and we're going to start off, of course, with the overall tab. Okay. But then one more thing, just as a refresher, most of you know this, but on virtually all of our screens, you will always see at the top 2 buttons, a PNG button that allows you to take an automated screenshot of whatever graphic is displayed on the screen, and then a CSV Excel button that allows you to actually download the numerical data into an Excel spreadsheet so that you can manipulate it yourself. Okay, we're going to take a deeper look at the overall tab now, though. Okay. So some of you know, we've had these bar graphs in the Maternal Data Center with these overall numbers for a couple of years now. Okay, we're just sort of bringing them to the fore so that you can find them a little bit more easily, but some of you might already be familiar with this set of bar graphs in the overall tab. But let me do a refresher for everybody. The top set of bars, okay, are going to show your hospital's performance on whatever measure you've selected. In this case, we're looking again at the NTSV cesarean delivery metric, which you'll be able to see at the bottom. The top red bar is your hospital's overall NTSV C-section rate. Okay. Each of the teal bars represents the NTSV C-section rate for each of these subpopulations served by your hospital. Now, what's really eye-opening about this kind of display is your hospital might have a fantastic overall NTSV C-section rate. In the case of this example hospital, their rate is well below the healthy people target of 23.9%. Okay. And that can sometimes mask differences between care for different populations. So when we do this breakout by racial ethnic groups, you can start to see whether care practices are in fact having the same outcomes for all of your patients or not. So again, each of these bars represents the NTSV C-section rate specific to each of these populations. And then, as a comparison, a peer acuity comparison, the bottom half of the screen shows the bars that represent the averages for hospitals with the like nursery level. And again, just like with the PDF reports, this will automatically display the nursery level that is shared by your hospital. So if you're a level 4 hospital, you're going to see the level 3/4 aggregated rates for all the other MDC participants. If you're a level 1, you'd see the level 1 aggregations. So this is a nice comparison for you where you can look at C-section rates for your Black population versus C-section rates for the Black women served by all the other MDC hospitals that are also level 3 and 4. Last thing you can do, again, most of you are already aware of this, but for virtually all of our graphics, we have a set of drop-down menus that lives right above the graphs themselves where you can customize these reports. So using the start date and duration drop-down menus, you can change the time period. The benchmark menu will allow you to show different benchmarks that get evidenced by this purple line. That's going to be a vertical line, and it'll show you what the benchmark is down here. And the benchmark options are usually, you can set your own hospital specific or system-wide target. And then there are also top 10%, top 25%, both for your state and for all MDC hospitals. So feel free to customize these. What is new that you might not have seen, that you haven't seen before on the graphics, is a new drop-down menu for a comparison population, okay? Again, the comparison population is what's going to show up in the bottom set of bars. It's going to default to show your pure acuity comparison for those hospitals that have the same nursery level as yours, but you would be able to open it up and you'd be able to change it to see system-wide averages. If your hospital is part of a multi-hospital system, you'd be able to see overall MDC averages if you prefer. Okay? Just make sure once you make your selections, you click the Go button. Some other things to note, okay? Once again, we've got our small count warning, okay? In this case, we are specifically highlighting those bars where there are fewer than 50 cases in the denominator for the particular measure. So let me just be really specific, okay? The N equals 37 here means that there were only 37 Black women at your hospital in this time period that were nulliparous term, singleton, and vertex. Okay. Now, again, we're going to highlight this whenever there are N's less than 50. But of course, you're going to have increasing confidence. The higher the number, the greater the confidence you have. If the N was less than 10, you probably don't, you take it with a major grain of salt. Once you start heading up from 10, your confidence increases in the robustness of the result. But again, be really careful with your interpretation for these. But so for example, for this others category, there were only 2 NTSV women that didn't, that fell into the other race ethnicity category. And so you're gonna take that result with a major grain of salt. If you're wondering now, well, who makes up others? Who makes up unknown? Okay, we have a link below the graph, and hopefully you can see my screen. Do you see the C mappings here? If you click on the here, it will take you to a table that shows you which categories represent the finer race ethnicities that we think of. So it will tell you that what groups Asian Pacific Islanders are made up of. What do we mean by others? What do we mean by unknown? So feel free to use that as your reference. One other thing while we're talking about where which group is bucketed into which category, okay. A note on the data source here, if you are a California hospital, we are getting the information on race ethnicity from the birth certificate. So it's that information that the birth clerks are collecting when they go around doing their patient interviews. Then they are collecting information on race ethnicity during the course of that patient interview in the hospital. Okay. If you are a Washington or Oregon hospital, the race ethnicity information is coming from the discharge data that you submit to the maternal data center. And you would need to work with your own hospital to find out how they are deciding to document a race ethnicity category that goes into your discharge data. Okay, if you scroll down on that overall tab below the bar graphs, you will see some numerical data, okay? It's exactly the same data that you saw represented in the bar graphs, but it's just presented numerically. And the really cool thing about it is this is where you can click into any of these rates or counts, and it will automatically take you to what we call our patient drill down screens, where we will be able to see the actual list of the 5 Hispanic women that had cesareans among the 14 that were nulliparous term singleton vertex. What does that look like? Once you click that rate, here's the list of the fallouts. And again, it's going to be automatically filtered for you. So we're showing Hispanic US-born women that were nulliparous term singleton vertex and ended up having a C-section. That is who's going to show up in what we call this fallout case tab. Okay, this is the actual list of cases. You would also be able to click into the denominator case tab and see the full set of Hispanic women that were nulliparous term singleton vertex. And what's really nice about this is that you can also really easily change the group. So you can use this drop-down menu and you can toggle over and you'd be able to go to the Black mother set of fallouts, the Asian mother set of fallouts, okay? Or you could choose to remove the filter completely. And once again, as you probably know with all our screens, you'd be able to print this out or download it into an Excel spreadsheet, with the caveat that you do need to have permission from your hospital administrators to download patient level data due to the security of the data. Okay, going back, we're going to start to talk about the next tab, and this is brand new from a taking a race ethnicity perspective to the drivers behind each of these measures. What do we mean by drivers? This is a breakdown of what indicators are really driving the measure results. And our intent behind the driver tab is to help you focus your quality improvement activities. Okay. So let me explain this a little bit more, and hopefully that'll become apparent. Okay. So the first thing I want to do is just mention, so we're now looking at the drivers, and I've switched over to looking at severe maternal morbidity, one of the other key measures for birth equity. Okay. And first I'm going to talk about the rows. Okay, so the first row is going to show your overall severe maternal morbidity, or our acronym SMM rate. Okay, so here's the count, and here's the rate for all SMM cases. Okay, that's going to be in the first row. Then the second row is going to show the numbers for the women that had a hemorrhage-related SMM. And the next row is going to show the counts for the women that had a transfusion-related SMM, and so on. Okay, so these are just all sub-buckets of the overall SMM rate. Okay, so which women had a code that reflected a hypertension-related SMM? Which ones had a code that reflected a sepsis-related SMM? Now, I do want to say these buckets are not mutually exclusive, because it may be that some women have both one of the SMM codes for transfusion and hemorrhage, of course. So there can be some quote unquote double counting in here because they're going to be reflected in both buckets if they have one of those codes that make up those buckets. If you are curious about the codes and what goes into it, I can't do it in the PowerPoint, but you can hover over this word and you would be able to see the major subcategories for that. Okay. So we just talked about the rows. Now let's start talking about the columns. Okay. So we are breaking the columns down into, again, own hospital data. So we're looking at gamma mu versus the peer acuity comparison. So the summary average for all other MDC hospitals that are level 2 hospitals. And then we're breaking it down so that for our own hospital, we are looking at the count and the rate for our Black mothers versus all other mothers. And what you really want to be comparing here is the rate for the Black mothers compared to the rate for all others at your own hospital. Now again, in the first row, we're comparing the overall SMM rate, and we are seeing a disparity. But then, and this is where the helping you focus your quality improvement activities comes in, okay? You want to look at, okay, how about those women that had a hemorrhage-related SMM, okay? Should I start there? And I look at the data, and I see that our Black moms had a rate that was about a 1.5 times the rate for all other women that we served. Okay. So that would be ripe for a quality improvement investigation. Okay. Transfusion, a little bit less of a disparity, still there, and we are dealing with some smallish counts. Hypertension, there is a gap between the 6.2 and the 2.9 for Black moms that we serve versus all others. Okay. Again, the numbers are small, but there's a gap there. Okay. And then the other categories probably don't merit your focus. So just compare the target community rate versus all others. And then you can also do that comparison for your peer acuity peer group. Okay, and again, looking at Black mothers, averages for all other hospitals, and then the all others at the other hospitals. Some customization features here. Once again, caution on small volumes. This is where it gets really tiny, okay? Because not only have we taken the overall SMM rate and we've parsed it into different race ethnicity groups, we have now taken that and we've parsed it into subcategories of the SMM measure, okay? So be very careful here. So make sure you look at that. One thing, you can again use these drop-down menus to customize this. Again, you're going to be able to customize the target race ethnicity group you want to look at. You're going to be able to choose a different comparison population. Again, you can choose your system average or your overall state average. And then you can also change the time period. Now, we're going to default to having a duration of a minimum of 12 months because of these small count issues, but do know that you can also change it to 24 months. And we do not let you do anything smaller than 12 months in these screens, okay? It's just, it gets too small. Okay. The other thing, as with all of our other screens, you can click into the green numerical data and you can drill down to the patient level here too. And if I were to click on this 27.0, what I would end up seeing is a list of Black mothers at my hospital who had a transfusion-related SMM. Okay, and you'd be able to see those fallouts. Okay, and then last, but by no means least, if you can see the very bottom of my screen, we do have a link for some interpretive guidance. If you click that, then we are going to give you a couple of examples of how to view these data. And so just know that that is there for you because we recognize it's a lot of information. Next thing we're going to do is we're going to go look at the trend tab. Again, this is all in the birth equity section, remember. So these trend lines are different from what you're used to seeing for the overall measure in that we're going to be showing you trends specific to the race ethnicity groups. So in this particular example, the purple line represents how the rate has changed over time for our Black mothers. And then the orange line represents how the trend has changed over time for everyone else at our hospital. Okay. This, of course, answers the question, are we making progress or not towards our birth equity goals? Once again, some customization options. Okay, we're going to default so that you see these data in terms of 12-month data points. So each of the data points on the screen is going to represent a 12-month period. Okay. And we did it again because we've got, we have to be very wary of small counts. Recognize we do have a rolling 6-month average option. Okay, if you're very curious to see if your efforts are making progress, we know folks want to be able to see that. But do be very careful about using that rolling 6-month option. Really, it's only large volume hospitals that that should be using that on a routine basis. And by large volume, this is it partly depends on how large the population is in your target groups too, of course. But you'll want to have at least 3,000, 4,000 cases deliveries per year before you start using the rolling 6-month averages. Okay, and then the last thing, and this is a little bit different from the other birth equity screens, but you are able to add as many of the different racial ethnic categories to the screen as you like. Just use this race ethnicity select option. And if you wanted to, you could add them all to the screen. It starts looking very busy. But just in this example, we could add both the trend line for our Black mothers, for our Hispanic mothers, and then we have the all others line, but we would be able to add all of the lines to this graph if we wanted to. Okay, and once again, you can drill down to the patient level right from here. Just click on the rate that is in the numerical data underneath the graph, or you can click on the data point that is in the graph itself, and you will see that patient level set of fallouts. Okay. So those are all of the new features in the Maternal Data Center. If we're going back to our home page though, you'll notice there's also learn more about the CMQCC Birth Equity Collaborative. So we do have a pilot collaborative going on with a set of hospitals here in California, but we encourage you to go look at this regardless, because we have a lot of resources that can really help. We've culled the literature for resources. So use this resource link, and there are some featured articles under the resource link regarding folks that are really trying to address the birth equity issues. Okay. So there's a lot of new data in here, and you're probably wondering, okay, well, what do I do next? Okay. And so remember, this is really about starting to inform yourself. So first step would be use the data center to identify and build awareness of any possible inequities within your own hospital setting. Use that CMQCC resource list to start educating yourself and your team. Engage your leadership and your clinical teams to identify what your specific areas for opportunity are. Don't forget about the leadership. Of course, you want to bring in your clinical teams, but a lot of things can also be addressed at the leadership level, because there may be some systemic issues that are best addressed at the leadership. So bring your leadership in. Build relationships with community groups in your area. We can't stress the importance of this enough. You want to talk to the groups that are serving your target community, and make sure that you understand their perspective. I'm going to leave us, before we go to questions, with this. This is a slightly different framing of what Terri showed you earlier with the bicycles. And this is just food for thought, that as we're reviewing this data, remembering that birth equity is all about learning how to best serve our diverse patient populations. So with that, if we have questions in the chat box, Terri and I are happy to take them now.
Thank you, Anne and Terri. We did have one question come in. For those of you who are on the call, now's your time to type your question into the chat box or to the Q&A. and Terry and Ann can address them in the last couple minutes that we have. There was one question that came in for you, Ann, that they don't have a baseline till 2017, so they can calculate their years on the 2017-2018 data for figuring out their birth equity data.
Okay, you know what? I'm assuming that would default to just showing the 2017 data, but if they could email us at the data center help desk, and they can let us know which hospital they are, then we'd be happy to help them out and take a look at it and make sure they're getting a baseline graph calculated.
Okay, and just for your information, Ann, that question came in from Sandra McGoldrick.
Oh, okay, great. That's Sandra.
Okay.
Okay.
The slides will be available. They'll be posted early next week on the CMQCC website under webinar resources. And there's another question. Are there any tools that CMQCC provides on mitigation strategies for implicit bias or training education? Terry, do you want to address that one?
I can tell you that that is work that is ongoing with the Birth Equity Collaborative. We do not have them finalized as of yet. We are really trying to focus our work away from just implicit bias, but really looking at cultural humility for all. And so that is going to be part of what is going to come out in our eventual goal is a toolkit for birth equity, but that is not available as of this time.
Okay. Another question for Ann. Will the others category ever be broken down into smaller populations? Specifically, our hospital serves a large Native population that isn't represented with the current ethnicity groups listed in CMQCC.
Yeah, we definitely want to be looking at that. And so we will, that is a phase 2 investigation for us, and we'll see what we can do. And again, if you wouldn't mind, and it doesn't have to be now, but just shoot us a message through datacenter@cmqcc.org so we can have this on our radar.
If the hospital doesn't add extra data, is there still information available in this new area? So it's not a supplemental file?
Absolutely. All of these measures, well, I'm pretty sure, I want to go back to my more measures list, but NTSV cesarean delivery and severe maternal morbidity are both auto-calculated even without supplemental data. And as the big caveat here is, as long as your hospital is including, let me back up. If you're a Washington or Oregon hospital, and you're including the race ethnicity field in your discharge data, which is part of the standard file specs, then it will get auto-calculated. Although I think there might be 1 or 2 hospitals that have not been providing that. So you'd want to go back to your own IT departments that generated the file if you're not seeing it. And for California hospitals, we're getting the birth certificate data automatically. So we have all the race ethnicity information for everybody without you doing anything at all.
Yeah,
so no, there should be no supplemental data requirements for those key measures.
Yeah, and I was thinking the only one that might is if you're choosing to look at exclusive breastfeeding and the more measures. That may be the only one.
Thank you, Terry.
That list again, but that one does require extra data.
Yeah, and I'll quickly go back to the more measures list, and yeah, breastfeeding does, actually there are a couple more. The blood product units transfused, we do need supplemental data on transfusions for that one. Ditto for massive transfusions, and the ICU admission rate also requires supplemental data. So it's basically these 4 that are sort of smack in the middle of the more measures that do require supplemental data. But all of the other measures on this list should be auto-calculated.
Timely treatment is the other one for hypertension.
Oh, I'm sorry. Yes, you're right. Thank you, Terry.
And if any of you on the call have questions about supplemental files or anything, just reach out to the help center in the MDC, and they can direct you and help you if you need help with that. One more question from Mary Mocknell. For hospitals that are part of a multiple hospital system, is there a mechanism to compare the systems to other MDC hospitals, or will it just be individual hospitals within that system?
What you'll be able to do is you'll be able to see your system averages if you choose that particular comparison group. And you won't, for the sake of space, you wouldn't be able to automatically include on the same graph the peer averages for the nursery level or for the state, but of course you could pretty easily download all those data and put it into a single Excel spreadsheet. So I think the question is there one graph where we can see all of the different comparisons? And the answer is no, not automatically right out of the maternal data center, but you could pretty easily create that graph for yourself by using that CSV download button.
Okay, thank you. At this time, there aren't any more questions. We appreciate everyone taking an hour of their time today to join us for this webinar, and thank you, Terri and Ann, for your presentation. If there's no more questions, any last comments from Terri or Ann before we sign off?
No, thanks everybody.
Yeah, just thank you for taking the time.
Well, great. Thank you for joining us today, and we will have the recording and the slides available early next week. Have a great afternoon, everyone. Thank you.
Bye.
Bye.